Hello, everyone. This is Alraies from CVI 2023 in Austin. I'm really privileged to be with Mahesh Anantha. He is an interventional cardiologist, a colleague. Every time we meet with him at CVI. And today we're going to talk about, first time, I think it's been a while, about carotid intervention. Mahesh,
Yes,
thanks for being with us.
It's always nice to meet you, Chadi.
Yeah. So tell us, as you know, the indication and appropriate use of the stenting and stuff has been kind of almost standardized, but there's some new literature about it. So let's go overview in general.
Definitely, yeah. So there are trials published in the past, registries and trials comparing endarterectomy versus carotid stenting, including the Sapphire trial as well as the CREST 1 and 2 trials. They all came comparing patients asymptomatic as well as symptomatic carotid patients. The current guideline that we use right now basically just supports carotid interventions greater than 50% in patients with symptomatic carotid artery disease, which includes same-site stroke, or they even considered chronic headaches and dizziness and pre-syncopal events, including symptomatic carotids. But for asymptomatic carotids, greater than 80% is the cutoff for intervention, and asymptomatics are only exclusively done by surgeons with endarterectomy. And for you to be doing stenting for these patients, you have to be part of some registry or trial. Otherwise, you can't be doing outside the settings. But recently, the interest is Medicare is actually coming up with updated guidelines and statement. And in fact, they released something last week basically saying 70% and above asymptomatic carotids, and they're going to approve for carotid stenting. They're just taking feedback from physicians online. There is the open thing available. If you type it at Google, and you can just go and enter your feedback. But 70% and above asymptomatic carotids, they're trying to support more for stenting. The reason being, they've not looked into trials for a long time. They're just trying to update the recent evidence. As it seems, carotid stenting seems more straightforward, and the evidence of stroke is much lower with us using a protection with the filter every time. So I think that's going to be the near future is what I'm thinking. So I thought I'll just bring up that topic and have a conversation.
So to summarize it then, is 80 asymptomatic or 70 asymptomatic?
Yes, exactly. Yeah.
Or any symptomatic?
Our symptomatic is going to be greter than 50.
50, yeah.
That's
which didn't change, yeah.
Yeah, exactly.
Okay, so how about the approach and technique? Anything new with the intervention?
So I would just like to share what I used to do. I do quite a bit of carotid interventions and learned it during my peripheral training. So I thought I'll just discuss basically the pre-procedural evaluation and the procedural aspects. So first of all, pre-procedural evaluation, I try to be open to the patient. It's like giving an ICD for a sudden cardiac death prevention. I have an open conversation with them, tell them about the risk of procedural harm with stenting and with surgery. So basically, there are contraindications, which are definite contraindication, relative contraindication. If it's a 100% occluded vessel, you should not be touching that vessel. That's basically the one major contraindication for carotid. But if someone has a contralateral carotid occlusion, or if they have prior heart disease, they are at high risk of going through an endarterectomy. So basically, these patients favor more carotid stenting. But other than that, a major tortuosity and calcification have to be very careful, and it's really important to plan for a procedure by using a pre-procedural CT scan. And if they have extreme levels of tortuosity, zigzag carotids, 360-degree circle, you're better off staying away and just not doing anything to them unless it's symptomatic recurrent strokes for them. So basically, these are all pre-procedural aspects I choose. And there's always a question about whether you sedate these patients or not. So it varies with practice. In my practice, I never sedate my patients. Basically, I just want them to keep responding to me, and we have a balloon that they hold on to, just a ball, stress ball. They can squeeze and they can tell us that they are awake and they are responding. Reason being, we want to make sure if there's anything that goes abnormal, transfer them immediately or take care of them acutely with thrombectomy or something if needed. Most of the times, we run into no major issues. The other thing we look for is possible seizures and bradycardia and hypotension in people when they are getting this procedure. So we just prepare for that with medications. So I always approach with groin access, pretty rarely go to radial access. And sheath-wise, I always use a 90 destination long sheath for procedures to get into the carotid. And to engage the carotid, we use the Vitek or VTK, people call it differences. It has a backward hook, like an Omni kind of inverted hook, and it'll hook up the carotid, the right carotid, and then you can pull back and you engage the left carotid, or the same thing for the left subclavian too. So I stay away from using JRs and stuff. The most important thing is engaging your carotid. Once you get into the carotid, you have the sheath in there, everything is easy from there. So the most difficult part is going to be going against the arch, and if it's type 3 arch, it basically is a big problem to even engage that. So I try to use a VTK or Vitek catheter or a Bernstein catheter, which is longer, and try to get into the carotid with an angled glide advantage wire, try to get some support. If there is not much tortuosity, I use destination to get better support. If there is so much tortuosity, we just go with a Cook sheath or some of the soft sheath, try to not dissect the carotid. And that can be a bigger problem. So once after we engage the carotid, we take some pictures. We just have to have 4 different views, the complete lateral view, RAO, LAO, and then we go transcranial at the Owen's view, basically to look at the filling of your brain. Once after we take some pictures, evaluate carotids in multiple views, if you're convinced it's greater than 50% in symptomatic patients with same-side stroke, then you have to do a filter, otherwise it's not reimbursed. And it's safe for the patients. The only disadvantage is you are still going through the lesion while you're passing a filter. So very small chance someone can have a stroke if they're especially 99%, you're trying to pass a filter. So you just keep testing. And the smaller particles, I've never had a problem. Even in 99%, we have put a filter across it. I've never had any major issues with that. So once after that, you get a filter in there. I usually use EmboShield. Takes a special preparation for that, making sure there's no air bubble or anything in there. I stay away from spider filter because it can keep moving, but your EmboShield has a distal overnight tip pretty similar to the CSI, so the filter doesn't move once after deployed, and you can always push it forward with the stentor balloon if you need to be advanced. Unlike the spider wire where you just have the same wire which keeps moving. So this filter is just mounted on the wire doesn't move, it's pretty stable compared to filter. So once after deploy that, I usually try to avoid predilatation in people. All you're caring about in this is squishing the plaque to the wall of the vessel. It's not about improving blood flow, it's more about preventing this plaque from traveling to the brain. And shapes for the carotid stents are all hourglass shaped, so you can squish the plaque to the wall of the vessel. And I usually prefer Abbott stents because they have this exact shape that you can push it to the wall of the vessel. And exact stent is what I usually go with. If we don't have exact stent, the proper size, we use wall stents from Boston Scientific. But the wall stents can stretch pretty long, covering a longer segment. The other thing we always make fun of...
and you avoid the ballooning just to avoid any debris to shower.
Any debris to shower.
One time shop. And
yeah, so exactly. So usually, once after stented, if it's extremely, extremely tiny ostium, then I try to post-dilate a little bit, but most of the times we try to stay away from this because all the stents are self-expanding, and they keep expanding over a period of 6 to 8 weeks, and the velocities continue to keep getting better in the future when we monitor these patients with ultrasound. Once after that gets done, we deploy take out the filter and just make sure that in multiple views the flow is okay and the procedure. So things that can happen during the procedure that usually concerns me, obviously neurological weakness and things that we want to monitor for by asking repeated questions to these patients, making sure they don't go bradycardic and hypotensive, and we have neo bolus to give it to patients, as well as we give them atropine before we deploy the stent or balloon to keep their heart rates higher. And also pre-procedurally, we stop all the blood pressure medication and beta blockers and anything for at least a couple days before the procedure to get off the system, and we try to avoid using any of hypertensives right after the procedure. And post-procedural care, usually put them in ICU and maintain their blood pressure systolic between 100 to 160, trying to use phenylephrine if the blood pressure is below 100, and try to use nipride if their blood pressure is above 160. And usually they get discharged the following day or the next day, depending on how the blood pressure is.
Do you hold any medication like beta blocker or anything?
So I hold all of the blood pressure medicines and beta blockers also to avoid bradycardia at least 48 hours before the procedure.
So what's the incidence of bradycardia post or heart block post stenting?
So I've seen in my practice at least, I have to just say the numbers that I do, probably around 4 carotids per month, and maybe sometimes more depending on how the referral pattern is. Where we see at least 50% of our patients will have this effect. Some of them don't have anything, and obviously some of them have pacemakers, so no problem, but we do at least see in 50% of our patients have significant bradycardia, but I see more of a hypotension issue than bradycardia, and we have to usually keep them on levofit for a day or so after the procedure.
Okay. And then follow-up, would you do ultrasound or CT?
So I usually try to prefer just follow-up with ultrasound and compare the velocities before and after. And I always use bimodality before I even sign up for an intervention with these patients. I use both carotid ultrasounds as well as CTA. Sometimes carotid ultrasounds can be fake from just tortuosity. I want to make sure we look at both and correlate velocity. And we usually try to sign up for carotid stenosis that are great velocity, the ratio greater than 4 is the cutoff. Or if significant velocity in systolic greater than 250, 300 in that range, then we look for that. But we go with the NASCET criteria and we establish and we compare that with the CT scan, make sure they both correlate. And usually tend to follow 1 month, 3 months, 6 months with carotid Dopplers, and just making sure the velocities settle. And usually it settles with because they're self-expanding. We had some complications not to expect. Sometimes people can get seizures during the procedure. You always keep Ativan and just get them ready. In that case, you still have to sedate the patients, obviously, when they're going for seizures. I have a couple of patients who had seizures while carotid stents being deployed, so we had to put them on Ativan and maintain them on Keppra overnight, and we took them off the next day morning.
Yeah, but yeah, that's very insightful about the indication of the new kind of revised kind of indication going to be coming up soon,
Right.
as well as going through a very extensive step by step about the carotid.
Yeah. No, I think as interventionalists, we are probably going to be getting more referrals with the new guidelines being updated, I think, and it's probably nice at this point with Medicare coming out with all this stuff for us to be aware of and start looking into this more.
Absolutely.
I feel.
Yeah. Mahesh, thanks so much for your time and for walking us through this extensive step-by-step approach.
Thank you again for the opportunity.
Please watch these videos and others on the YouTube channel. This is Alraies from Austin. Thank you so much, Mahesh.
Thank you again.